So can I just throw out one or two questions that go a little bit outside the box? Is anybody using carbodoxil up front? And two, is anyone using single agent? And what patients would you consider?
The answer to no is, to both for me, is no.
I mean, I think in a situation where there's an absolute contraindication, such as, you know, high-grade pre-existing neuropathy, it would be a consideration.
Yeah. Unfortunately, the study that we were alluding to that could have answered that question chose not to, right. Meaning it was not an adequate sample size. I mean, there was a phase 3 randomized trial that directly looked at it, and instead of doing the number of patients, they had a much shorter. It was a very encouraging outcome, but did not provide a definitive answer. At least that would be my interpretation of it.
And I don't know that we cure more patients now than we, I think we're shifting the overall survival statistics in a favorable direction with the multitude of active regimens that are used in the course of a patient's disease. So sequence, I'm not sure, is necessarily critical, which does raise the question of you know, whether the frontline regimen can be modified in such a way.
I mean, to answer your question about single agent carboplatin, what amazes me is the number of older women, you know, octogenarians or women in their 90s actually can tolerate, you know, paclitaxel and carboplatin chemotherapy perfectly well. And you know, in my institution for years we used single agent carboplatin, but when you actually give both, it's amazing how well those women tolerate that therapy.
Well, interestingly, the ICON-4 trial in the recurrent disease setting that for the most part compared single agent platinum to combination taxane platinum showed dramatically less myelosuppression overall with the combination, but more neuropathy. So the overall toxicity was not much different between the two. It was just a different type of toxicity, and it depends on what kind of toxicity the patient's going to be able to tolerate.
And the only other setting that I certainly have seen, and we all see this elderly individual with cancer of unknown primary, and you know you think it's an adenocarcinoma, you don't know it's ovarian cancer, you're not sure what it is, but single agent carboplatin is so well tolerated that you give it a try. And obviously if the cancer, you know, the ascites goes away and then it was gynecologic and you can go on. But I think there's a setting where, you know, that you don't think there's a high probability it's going to work. A woman's going to lose her hair, there's additional toxicities, but single agent carboplatin is just so well tolerated that it's almost a therapeutic trial. And if nothing happens positively, you've given it your best shot. If a patient has a good response, then you just address it. So I certainly would, there are patients like that. The next question, we sort of talked around it, the role of bevacizumab in the frontline setting. Tate, what do you think?
We use bevacizumab as a part of our standard treatment frontline, platinum sensitive setting, and platinum resistant setting. The data are I think, overwhelming. You have 2 large upfront studies involving more than 3,300 patients that show a consistent progression-free survival advantage. In a setting where when the patient progresses and goes off that treatment, the patient is going to receive up to 8 or 10 additional lines of therapy, which is going to completely blur any ability to distinguish a survival advantage. Now some people want to argue that, well, why not just give it in sequence anyway, and therefore they'll live just as long, but they'll spend more total time on treatment in all likelihood. So I think that bevacizumab is an important part of the treatment. Now, some people contend you can't assess progression-free survival consistently, but we have 4 studies, 2 in the frontline setting, 1 in the platinum-sensitive setting, and 1 in the platinum-resistant setting, totaling over 4,300 patients that all get the same result. That is progression-free survival advantage. And in 3 of the 4, the progression-free survival advantage is very similar. In the 4th, where half as much bevacizumab was used, you get half as much impact as you got in the study where you used a higher dose of bevacizumab. So to me, the results are consistent. They involve a large number of patients in 4 different studies carried out by 4 different groups of people, all getting the same answer. So that I really strongly feel that bevacizumab ought to be a part of our standard therapy outside of clinical trial for ovarian cancer. And I hope that the FDA is going to agree with virtually every other regulatory agency in the world and draw that conclusion in December when they review the results in the platinum-resistant setting for bevacizumab.
So they just